Anyway, welcome everyone. We just wanted to let you know some of the terminology and some of the things that we have been working on as a CCC, and we're going to explain what that means as we go as we go along today. Dr. Wilson and I chair the CCC. Of course, Jennifer Kurtz is really in charge of it, as we all know. And then Dr. Shu and Dr. Rainey also sit on the CCC. And so the main thing that we do is meet at least twice a year to go over everyone's progress as residents. And the ACGME puts out information for us to be able to assess that progress. And so this presentation was in large part done by the ACGME, and we're going to go through some of this quickly with you so that you have some framework by which sort of we understand and do these assessments every year. So anyway, please feel free to stop us as we go along if you have comments or questions, and then definitely everyone who's on the CCC chime in as we go along. So basically we want to introduce milestones to you, and the big thing is that it's the framework for competency-based medical education, which is a little bit different than how medical education was traditionally administered in the past. So we're really going to go over the milestones, what they are, how they were developed, and then how they serve you, how they serve the CCC, how they serve the ACGME and the ABFM as well. So it's really important for you guys to be able to know what the milestones are and to review them. The ACGME has like a site where it's just for residents and fellows, and Jennifer's going to put the link for that site in the chat. So if you're interested in seeing it today, you can, but I would definitely ask that you click that link at some point and bookmark it so that you'll have the ability to access the resident and fellow section of the ACGME that deals with milestones. So basically, you have to do a self-assessment twice a year, along with the assessment that we're doing as a CCC. And then it's sort of your job to compare your own assessment with the assessment of the CCC. And then you're supposed to be writing an individualized learning plan. So what is it that you want to get out of your education? And I know we ask you guys this a lot in different forums. Like when you're with your advisor, you're going to be asked, what are some of your learning goals and plans? And sometimes when you're with Dr. Witt, he may ask you, what are some of your goals and plans? And some of you come to each one of us as directors, or maybe a local mentor, and say, hey, I have some learning goals and objectives, and here's what I would like to do to achieve those. So that's going to be all sort of folded into your competency-based assessments here. And then definitely always actively participate in assessment and feedback. All right, so competency-based medical education, it's really very outcomes-based instead of like times-based. A lot of times in the past, and this is where some of the changes happened recently with the ABFM, where it was you had to complete 36 months of education. Now they're saying, well, really, you don't have to complete the full 36 months if you had leave for something, say having a baby or some other medical condition that you could actually be done sooner than 36 months if you meet the criteria for the competency. And so this is a bit of a change from in the past where we had a lot of like rotation-based or time-based assessments and milestones and markers. This is more competency-based. And so it's important to kind of understand that. So how is competency-based different? So the traditional model, there's a lot of driving force in the knowledge and getting that knowledge, but this, the competency-based is like, how do I apply that knowledge, which obviously makes a lot more sense, particularly in family medicine when we do so much patient care and such a broad variety of patient care. And then the driving force for the process in competency-based is really you. So this is where you sort of take ownership partnership for your education. Yes, we have certain parameters that you have to meet, but this is where you say, okay, here's my specific learning goals, and that drives the process. Again, we're looking more at the knowledge application. There are lots of assessments that we use now. It's really very interesting, and there's a graphic coming up soon where we take in data from all kinds of places and we sort of assimilate that, and then we come up with a summary for you. And then the assessment tools, we have so many different assessment tools that it makes it a little bit more authentic. And we can see trends, and we can help point out trends for you when we're taking assessments from different angles. And then the timing of the assessment, it really just is more about how you're formative, how you're developing as a physician, and not as much on like certain, you know, random standards or whatever. And then again, the time component used to be very fixed, and now it's somewhat variable. So those are some just basic difference between the competency-based medical education and then the traditional model. All right, so why did we choose competency-based? Why did the ACGME choose competency-based? Because really it's in looking at some of the assessments, it helps you understand what skills are needed for best patient practices, for quality and safety measures, for best outcomes for your patient, and then also best for your learning. And then it helps to also standardize the training so that if you're being trained here, or if you're being trained in Nevada or in Connecticut, that the milestones that we expect you to meet in family medicine are going to be the same. Obviously, the learning experiences may be a little bit different, but we're able to better standardize across various institutions. And then we mentioned that there's more evidence-based here as well, so that helps. If there's things that are happening on the chat that I need to know about, I'm going to trust someone to let me know because I'm not actually watching it. All right. And then also there's more direct observation of behaviors and skills as opposed to like tests or metrics that way. All right, so everybody, all residencies have the 6 core competencies, and I think most people are at least remotely familiar with this: the patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. And we'll kind of dive a little deeper into each one of those, but that's the overarching 6 competencies that all ACGME accredited residencies have. Now, each discipline, family medicine core competencies will be all of these 6, but their sub-competencies may be a little bit different from family medicine to ENT, but all of them have the 6 major core competencies. So what you need to know is that the milestones are what we use to help to understand your progression, to help to show growth, because that's what you're here for, is that you're going to come in with a certain amount of knowledge and skill set, and then the whole idea is that you're going to grow as you're going through residency. And so that's where the milestones really help us to assess that. So let's see, it describes the progression within those competencies. You understand what milestones are, we understand what milestones are, and then we can kind of all speak the same language. That's why we're having this session today, to kind of go over that with you so that you're aware of the terminology and some of the language. That way, when you meet with your advisor, you meet with Dr. Witt, or you meet with someone from the CCC and they sort of go through it, you'll be familiar with that. And then all of this information is then sort of distilled by the CCC, and then we submit it to the ACGME. I'll explain a little bit more about that later. All right, so the Dreyfus stages, they're like a model to describe growth in education. And so these are sort of the milestones. You have the novice, the advanced beginner, competent, proficient, and expert. And so the milestones are formatted after the Dreyfus stages. And so when you look at them, a level 1 will equate with a novice, and a level 5 will equate with an expert. And really, a level 5 should be someone that's postgraduate. So there's no thought that you should be at a level 5 at the time of graduation. All right. And they talk about the different stakeholders, right? So the people that are involved in caring about how you progress as a physician. Patients, of course, you yourselves are obviously have some stake in how you progress. So do we, the program leadership, and then of course all of your accrediting and certifying bodies really care about how you progress and how you grow as physicians. All right. It's nice because it does have a roadmap. You can see what you have to do to achieve certain levels of competency. And I like that because there's nothing that's hidden. If you want to be a level 4, this is what you've got to do. And so I'll show you that here in a minute as we break down each of the sub-competencies. I also like the fact that it encourages sort of that self-reflection and assessing your own plan and where you are now and where you want to be, because so much of education now is very goal directed. And so I like that part too. And then it does help us to give you feedback because it's all standardized. So if you're functioning at a level 2, but normally should be at a level 3, then we can talk about, all right, what is it that's keeping you at a level 2, and how can we get you to be a level 3? Yeah, and it helps you to sort of set your own goals for improvement. On the program side of things, it helps us to develop the curriculum because we can say, all right, if we apply this particular parameter of a rotation, then we'll say that really applies to the practice-based learning and improvement, or that really applies to professionalism or communication. It helps us to understand what components of the education sort of apply to the different milestones. And then it also helps you to understand very clearly what the expectations are, so that when you look at the milestones, you can say, yes, I'm actually at that 3 or 4 level. And it's very clear between you and us of what that means. The nice thing also for the CCC is that as we're sort of distilling all of this information, it's nice to be able to categorize it. So if one of the MAs tells us, hey, Dr. X is always very kind and compassionate with patients and always calls them back with their abnormal lab results, and I've seen him or her really spend extra time with the patient. We know we can put some of that into communication. We can put some of that into professionalism. So it helps us to understand your behaviors and some of the accolades that these people tell us about you and how wonderful you are. We know how to put that in the right category. And that also helps you say, well, I would really like to improve in an area. And again, those areas are better identified when all of this information is distilled. And then, of course, how does it benefit the ACGME? It really helps them to know if we're doing what we say we're doing and if we're producing high quality graduates, which we always have and which all of you are. So it just helps them to be able to have a system to assess that. And then, of course, because we're accredited, it helps the public to know that we are doing all of the things that we say that we're doing in order to achieve that status, which is very important to us, particularly programs like us that have been around for so long. Some of that longevity is because we've been so particular about making sure that we have the ducks in a row that we need to stay accredited and to show the ACGME and the public that we're continuing to produce very high quality docs like you guys. All right. So anyway, there's been milestones, but they just went through a revision and they became active as of July 1st, 2020. So if anyone saw the milestones from before, they will look similar to milestone 2.0, but there are some differences. And so if you notice a few variations, that's why. They just went through and they sort of refined them. They made some sections the same through all residencies so that a physician could be compared the same, you know, whether they're in ENT or in family medicine or in emergency medicine, that they could be compared the same in certain ones of these competencies. And then, of course, many of them are specialty specific. So. All right, this is kind of that graphic I was telling you about earlier, and I like it because it helps to understand that we're really getting information from lots of different places, and we're going to separate that out again for you in a minute. But I like this graphic because we're talking to the staff, we're talking to your peers, we're talking to those who advise and mentor you, we're talking to our program director, we're talking to your faculty that supervise you in the hospital. We're talking to the residency staff like Jennifer and Amy, and how are you about getting your paperwork done and turning things in. So we are actually getting data from all over the place. So you used to hear about 360 degree evaluations, and this is sort of our version of the 360. So it's not actually just a piece of paper, it's information that's brought in from lots of different areas. And then we meet 2 times a year as a CCC to go over this data that we're getting, and then we send that information into the ACGME. All right, so when we take this data and we put it into your own personal sort of pocket in new innovation, here's an example of what a report could look like. So here's a resident. This is not anyone that's in our residency. It's just an example given by the ACGME, but you can kind of see this person in the middle of the year of academic year 14-15 was not even at a level 1, which is not uncommon coming in from medical school. So if you ever get a rating that's not meeting level 1, do not panic. And that's the other thing Dr. Wilson and I were just talking about this morning. All of us want to rate ourselves at level 5 because that is the type of physician that we aspire to be. And all of us are used to having all A's and being on honor rolls and, you know, having very high marks. So the fact that you're not getting a 5, please, please, please don't put any stock into like that. That means you're not achieving, because you are achieving. You are achieving where you're supposed to be achieving. And if you're not where you're supposed to be, we will tell you. But don't worry if that you're not even a level 1, or if you're right at a level 1 or something like that. Please don't panic, because this is to show growth. If everyone came in at a 5 and stayed at a 5, then that's like, how is that helping you? Because you haven't grown as a physician, right? So we expect that you're going to come in here under level 1 or at a level 1, and that you'll go up slowly as you go through residency. The ACGME has sort of developed these so that you would be at a level 4 by the time you graduate, but it is not a requirement that you are at a level 4 in every subcompetency to be able to graduate, okay? So this one just kind of shows this person's gradual progress over the year. Again, we submit in the middle of the year and end of the year each for each year of your residency. Okay. This is more of the graph that we look at. This is a spider graph, and you can see all of these competencies are outlined here and their sub-competencies. So this is patient care 1, patient care 2, 3, 4, and 5. And then medical knowledge, systems-based practice, practice-based learning and improvement, professionalism, and communication. So this is what we look at. So this one would be in the beginning of the year, or actually the end of the year from one academic year, and then December is like the mid-year from the next academic year. And we want to see that there's growth. And so that spider graph should continue to get sort of farther out from the center, and that helps us to determine how there's growth. And you can kind of see right here, something happened in systems-based practice where there's actually a little bit of a dip for this person. So that might clue us as a CCC or your advisor or Dr. Witt to say, hey, what's going on there? And then take a deeper dive into the data that caused that point to show no growth and actually a little bit of regression. Does that make sense? All right. So the ACGME recommends that you review your milestones regularly and that you do a self-assessment twice a year, which Jennifer will be sending out to you. And those will go live today, and you will have until the end of November to fill out your self-assessment. Then we want you to be able to review and compare your self-assessment with the assessment that's given by the CCC. Now, you probably won't have access to the CCC assessment until mid-January, because that's how long it takes us to distill all of this information, come up with scores, and report those to the ACGME. So, but at that point in time in January, it's nice to take the CCC assessment and your own self-assessment and compare those, and then kind of create some learning goals for yourself. There's a lot of resources on the website, and Jennifer was put that link, I believe, in the chat. So you can, there's a whole like guidebook, there's a whole bunch of information for you on the ACGME website so that you can take a look at the milestones. And there's a CCC guidebook you can take a look at. And then also there's a milestones national report, so you can see where we compare with other programs. All right, so here's a reminder of our 6 core competencies, and then I was going to break them down into sub-competencies for you just to show you kind of what we are looking at, and also so you can see what you will be looking at when you're filling out your self-assessment. Besides the self-assessment, you will also be filling out a peer assessment on each one of your fellow residents. Now, I know that seems daunting. I know it. But I'm telling you that this information is so helpful to us and also to your peers in hearing what you think about them and their practice of medicine. Last year, this time, we sent out self-assessments and peer assessments. I had to personally contact several of you to tell you to finish the self-assessment because we really have to have that one. But then for the peer assessment, I think the most we had on any one resident was 7. And I would say we averaged like between 2 and 4. Correct me if I'm wrong, Dr. Wilson or Jennifer. Like I would say the most we had on any, or the average on most residents was like between 2 and 4 peer evaluations. As you know, that kind of power is not going to help us get good data. So again, I know it seems daunting, but please, please, please fill out the peer assessments so that we can provide really good data and feedback to all of your peers. All right, family medicine milestones, same as the rest of them. They went up to version 2.0, and then again, they break down each one of those core competencies into sub-competencies. So in looking at the first core competency is patient care. So this is the first sub-competency, care of the acutely ill patient. So they want to know, okay, not only how well do you take care of patients, but let's break that down. Let's take a look at how well you take care of someone who's acutely ill. So a level 1 would be like you can get a good differential diagnosis, you understand the role of clinical protocols and guidelines, and then you realize acute conditions have the impact beyond immediate disease process. I would say most people come in at a level 1, potentially maybe not quite a level 1 because sometimes creating a very good differential diagnosis is difficult for people who have not had a lot of experience working with acutely ill people. So, and then you can see as it goes from level 2 to level 3 to level 4 to level 5, if you're an expert, which is level 5, remember, you can say that they efficiently manage and coordinate the care of multiple patients, including life-threatening condition. They use resources to manage complex patient care environment, and you implement strategies to address the psychosocial impacts of acute illness on populations. So, you know, that's how you would grow in patient care, sub-competency 1, acutely ill patient. So when you look at the next thing for patient care, now they want to know how you take care of chronically ill patients, which obviously this applies a little bit more to the outpatient setting. The first one applies a little more to the emergent and the inpatient setting, sometimes in the outpatient setting for sure, but more so inpatient and ER. So you can kind of see they're getting at different aspects even within that competency. How do we take care of acutely ill? How do we take care of chronically ill? How do we do with wellness and health promotion? That's PC3. PC4 is ongoing care. When people come in with like weird symptoms or undifferentiated, how do we take care of those people, and how are you growing as a physician in understanding that? And then PC5, this is new this year, managing procedures. So we will be taking a look at your procedure cards and procedure numbers and some of the competency-based assessments that we have as it relates to your procedural care. So that's patient care 1 through 5. Then we move on to medical knowledge. We want to know about how your like core knowledge, the breadth and depth to be able to practice family medicine. So you can kind of see how those progress as you go through 1 through 5. And then we also want to look at not just like how you take tests and what your breadth and depth are, but like how do you get there? What are the critical decision-making skills that you have? Excuse me. So that's medical knowledge. There's just 2 subcompetencies there. Systems-based practice. This is where we deal with patient safety and quality improvement. Excuse me. And this is going to be really important because those of you who sit on peer review committees and those of you who are involved in like root cause analyses or anything to do with quality and safety, it's going to be really important for your development as a physician. Some of you who may sit on, it used to be called the infectious disease committee. I don't know what it's called now, but how we prevent central line infections and how we prevent urinary tract catheter associated infections and what is our C. diff rate and all of that. Anything that you're working on for quality improvement will help to contribute to your ability to grow in systems-based practice, number 1. And then systems-based practice 2, this is like more of a patient-centered care. So how do you help the patient navigate the system that is healthcare? This one is how is the physician's role sort of playing out within the system? And so you can talk about how you advocate for the patient within the healthcare system. And then this is new this year. Systems-based practice number 4 is advocacy for our profession. So how you're involved in that is going to be now implemented in the 2.0 family medicine milestones. Moving on to PBL, we call it Plebly. I don't know, we have to have something that makes it fun, right? So we call it Plebly. This is Plebly 1, and this is evidence-based practice. And you guys are very familiar with this and very astute at appraisal of the literature. So we just want you to continue to grow in that. This is Plebly 2, which is your commitment to personal growth and how you like assess your own practice. So that's good. And then we move on to professionalism. This is how your professional behavior and your ethics. Again, these sort of levels are pretty self-explanatory. And one thing I will point out, which I didn't point out before, is that you can be like a level 1.5. Like you can see there's a box here. It's not, you don't have to be 1 and then a 2. It's okay. There are half marks here. So if you're performing your own self-assessment or assessment on someone else, then you can mark those half marks. Professionalism 2 is accountability and conscientiousness. So if you're not turning in your paperwork, if you're not attending new conference, if you're not following through on commitments, that will affect your professionalism P2 score. So we really want to encourage and promote and develop all of us to be accountable in our practices. And then this one is new as well, self-awareness and help-seeking behaviors. Well, it was in before, it's just kind of a little bit more rephrased. So, how aware are you of your own well-being, and how do you seek help when you need it, and things along those lines. And not just necessarily for wellness, but also for your academic performance. And then here's your communication, patient and families. How do you communicate with them? And then how do you communicate with your team? How do you communicate with others in the healthcare system? And that's it. So that's a very quick, brief overview of all of our sub-competencies. And I wanted you to have just a kind of snapshot of what all of those look like. So just go ahead.
If I could add. So like Dr. Bunch said, you guys will all be doing a self-evaluation of those. You'll see at the bottom, there's a spot for comments. Looking through like evaluations of like rotations and that. Some of you are very good about giving comments. Others are less inclined to do so. But like there are some things that you do that we don't know about. Things like advocacy. We've had residents in the past that were involved in a lot of like, committees at the state level and that sort of thing. We may not know that. So, this is your chance to let us know. Put it in that comment sort of section. Because if we don't know it, we're not going to be able to give you credit for it. And then also, if you didn't do that, and when you get your milestone scores back, if you say, well, actually, I do this, this, and this, that will help us, and we can adjust things. But I would encourage you don't have to put a comment on every single thing, and you don't have to write paragraphs. But particularly if there are things that you do that are perhaps unique or outside of the realm of what everybody else is doing, that would be a good thing to put in a comment.
Yes, absolutely. Thank you for bringing that up.
I would also add one thing too. These evaluations are probably best used with a lot of sincerity. You don't necessarily, this is not a chance to like inflate your scores. Your pay is not attached to these. Your while standing in the program is not attached to these, but it's also not a time to be overly humble either. And so if you have something to brag about it. But if you don't, be really sincere and introspective about it.
Absolutely. Yes. Thank you, Dr. Rainey.
May I add one thing?
Sure.
Thank you, Dr. Bunch, for that really wonderful synopsis. As residents go through and attempt to self-evaluate, one thing that happens frequently is they may find that they meet all of the things under level 1. They may meet all of the things under level 2. And they may say, well, I'm doing a lot of these things under level 4 and some of them under level 3. And so how do I rate that? Do I rate that as a 4 because I'm doing some of that stuff or what? And the way that we as a CCC, which actually I should say the way that the CCC looks at it, is what is the level at which you're meeting all of those things consistently? And that is the level that you're rating yourself. So in that example that I gave, if you're consistently doing all the behaviors under level 1 and 2, but the stuff under level 3 and 4 are kind of like, yeah, I'm doing that some, but I'm not doing that like Dr. Moracle was. I'm not doing that like Dr. Bunch is. Then those are things that you'd either rate yourself as a 2 or a 2.5. So it's okay if you're doing, it's actually great if you're doing some of the stuff under level 4, but you kind of go back to rate yourself where you're consistently performing.
Right. Yeah, that's very helpful. I think sometimes it feels a little daunting to fill them out because again, we do look at level 4, level 5 and say, well, I do some of that. And so it is hard to figure out where you land, but that was very helpful. All right, so this is just a little bit of a recap, helps you understand where we're getting all of this data. We get it from rotations, from people that you spend time with on rotations, your faculty preceptors, and also like if you had an upper level or you were a supervisor upper level and your intern evaluates you, we get all of the rotation data. We get data from our clinic staff, from the MAs, from the behavioral health, from pop health, from our schedulers, our front office. We get information from all of the clinic staff as well as the staffing physicians and their interactions with you. We do chart audits and we take a look at your completions, your chart completion rate. And so that data gets sort of filtered in. We review video recordings of your office visits and watch your patient interactions. We take a look at your procedure cards and how you're doing with your procedure competency and also volume. We take a look at your ITE scores and use that as a benchmark for some of your medical knowledge assessment. We look at your noon conference attendance and take that into account in both your medical knowledge and your professionalism. We look at your professional compliance with completion of your duty hours and all of the other things that you're supposed to be logging and new innovations. We look at whether or not you're completing all of your required modules. We get information from your advisors and how your advisor feels that you're rating on the milestone scale. We get information from our ancillary staff, which is what Jennifer used to describe herself and Amy, but I don't really like that term. We get information from the people who run this place. And how are you doing with turning in all of the things that they ask you to do, and how do you interact with them in a professional way? We get information from your peers and from your self-assessments as we've been discussing throughout this. So it's a lot of data that we distill. So what the process for this fall semester will entail, the CCC will meet and we'll review all the evaluations, and then we'll categorize them into your competencies and sub-competencies. And like Dr. Wilson said, the comments help us so much, because then we can sort of insert the comments in each competency and where sort of that comment belongs, if you will. And then summary will be sent to your advisor and also to Dr. Witt. And then each of you will meet with your advisor or Dr. Witt or both and review your CCC sort of evaluation. And then it's Jennifer Kurtz puts everything in and sends it all to the ACGME by about mid-January. That's when it's due. So this process will kind of be a little bit of a whirlwind. You probably won't feel the whirlwind part of it as much as we do. But I really just want to use this opportunity to, again, encourage you strongly to get your self-evaluation done and also your peer evaluations done. Pay attention to what rotation you're on. Pay attention to what rotation you're about to start and to determine how much time you're going to have to fill these out. So if you're getting ready to start a really time demanding rotation, I would encourage you to start today and finish it this week so that you're not feeling strapped as you enter into this new rotation. And it really helps us to have you not filling them out, scrambling, you know, during the holidays or whatever. So please pay attention to your schedule, both now and then what your next rotation is going to be. Yeah, we just talked about that. And that's it. So we are now going to have discussion, questions, thoughts. Nobody has any thoughts. Everyone, the overwhelming feeling I'm getting is that everyone is super excited about the milestones. So Jennifer, send them right now. Send all those evaluations. See, look, you just hit send. Any other words of wisdom from the CCC members, like things that we need to emphasize that I forgot?
I think that the more, obviously the more effort that you put into these sorts of things, the more you're going to get from it. So, we hear from residents all the time, and we know feedback is really how you grow. So, being introspective and, evaluating your colleagues also will definitely help them grow.
I would also add too that because we're such an integrated site, we, as Dr. Bunch was just saying, we interview a lot of different people. If there is a professional field or some specific people that you haven't spent a lot of time with, go ahead and start doing that so that when we do go see them, they don't just say, well, I don't really know, I haven't had a lot of time with them.
Or who's that? Yeah.
Think about some of the people that you just haven't spent a lot of time with and spend a little time with them.
And I think, those of you had the opportunity to meet with Dr. Witt last year after we sort of curated all of the comments and put together the spreadsheet after the fall semester last year. I think many of you told me that interaction that you had with him and the ability to see some of that feedback, like Dr. Rainey was just saying, was really meaningful to you, and that it is formative in terms of how you grow as a physician. Now, I will say, obviously, we weren't able to do the same type of spreadsheet and distillation of comments and evaluations that we normally would in the spring semester because of COVID, but it is our goal to be able to provide that to you twice a year. And be sure to take a look at these links that Jennifer sent out in the chat and then bookmark those so that you have the opportunity to check those later if you have questions or you just want to read a little bit more about them.
So I may take the opportunity to also say that these milestones are useful in terms of your summative evaluation. Most of what we've talked about today is in reference to formative evaluation. How can we plot you where you're at now, give you that data, and let you introspect and let you set some goals and move forward in formative type of fashion. We also use the milestones in your summative evaluation. And so anytime you finish a program, a training program, be it medical school or even undergrad, you had a transcript. That transcript showed your grades, it showed what courses you took. That basically is a reflection of your performance. And in medical school, you even have a dean's letter. If there's anything akin to the summative eval, it would be like that dean's letter. And the summative eval of your residency will show kind of where you're at on the milestones. And I might be able to actually show you the template, what that looks like. I think you're going to see it now. That's not quite it. Let me try that again. It's not showing the right screen. Now you might be able to see it.
Yeah, we can see the spider graph and the competencies evaluation.
So the summative evaluations that we use at the end of training will verify your training dates and information. It'll verify that you weren't on probation and weren't suspended and all of that kind of stuff. And then this page 2 on the right here is showing that sort of radar graph that Dr. Bunch showed earlier. And just shows the kind of your competency growth compared to what's expected. And then down below, we show the procedural training that you've completed, certifications, a little bit of narrative, and then the final recommendations on a summative eval include that you are recommended without reservation, that the training you've received is sufficient for independent practice of family medicine, and that you've achieved the essential skills and competencies to practice independently. And those are the type of things that your future employers want to know and want to see.
Okay. And, we want this to be a forum where you feel very comfortable. If you have questions, obviously Jennifer Kurtz is like unbelievable resource because she just knows everything. But so she can help you kind of navigate if you have questions about where to look or what we're looking at. But you can also come talk to any of us that are on the CCC, myself, Dr. Wilson, Dr. Shu, and Dr. Rainey, and we're happy to help you kind of navigate that as well. All right. Well, if there are no other questions or thoughts, then we'll go ahead and finish up for today. But be looking for those evaluations and get them done. It's a hard due date of the 30th of this month. So again, I can't emphasize enough, plan that into your schedule, figure out what rotation you're on and what you're going into and what your time frame will look like so that you can get them done without adding stress to your life. Or to
Just like voting, make a plan.
Yeah.
Do it.
Yeah. Yes. Sometimes early voting is like 12 to 15 minutes, I hear, and sometimes early voting is 2 hours. So make a plan. Okay. Thanks, everybody. You're all great. We're really blessed to be able to work with you, and it's an honor to be able to take a look at all of these evaluations and see all the positive comments that everyone makes about you and be able to share that with you in a really productive way. So, all right. Have a great day.